Hello, this is Dr. Sarah Wise from Atlanta, Georgia. And today I'm going to talk about central compartment atopic disease, which may be a topic that some of our audience is familiar with and others may not be as familiar. I hope to give you an idea of what constitutes central compartment atopic disease, which is a newly described entity in sinonasal disease. I hope to provide some information on why we think this particular disease entity occurs. We'll talk about patient evaluation and management outcomes, as well as some geographic differences and a few other topics as well. These are my disclosures. I'm recording this lecture on December 17th, 2024, so these disclosures are current as of this date. I'd also like to acknowledge my colleague, Dr. John Delgadio, who together with our group at Emory was on the forefront of describing central compartment atopic disease. So as we think about the association between allergy and chronic rhinosinusitis in general, previous literature has been fairly mixed on the association between these two conditions, allergy and CRS. In 2014, a review was published that looked at CRS with and without nasal polyps and found mixed evidence for association between allergy and CRS, and you can see the breakdown here on this slide. In the 2021 International Consensus Statement on Allergy and Rhinology for Rhinosinusitis, a large literature review was done that looked at allergy as a contributing factor for CRS with and without polyps. And you can see that the aggregate grade of evidence is relatively low level, with fairly few studies contributing to this evidence. So for CRS without nasal polyps, it was a grade of D, and for CRS with nasal polyps, a grade of C. So how did we get to central compartment atopic disease? What is central compartment atopic disease? What led us to describing this condition? And what is its association with allergy? And I hope to kind of provide some background and show you that this particular type of sinonasal disease seems to have a pretty strong association with allergy. And so we'll start exploring that with a case of middle turbinate polyps. So this is a 21-year-old man who complained of nasal congestion, sneezing, and itching, noted a primary trigger of cat exposure, and had a bit of improvement with some intranasal corticosteroids and intranasal antihistamines. So as we look at this video, we're looking at the patient's right nasal cavity. So the nasal septum is on the right side of the screen. We can see a large polyp. And as we examine that more closely, we can see that that polyp is pretty closely associated with the middle turbinate, and it actually is attached to the anterior aspect of the middle turbinate. It does not come from the sinuses themselves. When we look at this patient's CT scan, we're looking at coronal views going anterior to posterior. We'll note that the sinuses have relatively little mucosal disease. We can see in the right nasal cavity, there's some opacification of the nasal cavity. There's a concha bullosa of the middle turbinate. And so that opacification of the nasal cavity is that actual polyp that we saw on the endoscopy. Again, note that there's relatively little mucosal disease present on this scan. This patient underwent allergy testing, and we can see here the results of the testing. There were a few negatives scattered in different classes on the testing, but there were lots of positives. So this patient was sensitive to lots of different allergens in various classes. And we can see in particular, as noted by the asterisks, that he was quite sensitive to cat, which was his noted clinical trigger on history. So middle turbinate polyps have been associated with positive allergy testing and clinical allergic rhinitis, and this was first described by our group at Emory in 2014. In 2017, independently, this was confirmed by a group out of Sydney, Australia, where they further noted that more severe polypoid changes, such as diffuse edema of the turbinate or multifocal polypoid edema, showed strong association with allergy. And then also in 2017, a group out of Ochsner Clinic in New Orleans noted that isolated middle turbinate polyp patients appear to be a distinct group from our standard and classic diffuse sinonasal polyps. So the classic CRS with nasal polyps. And we can look at some of the findings of their study here. So this table shows differences in patient demographics and comorbidities. And we can see in the far left column are the characteristics that were investigated. The first column, PSP, is paranasal sinus polyposis. And then the next column is polypoid changes of the middle turbinate. So polypoid changes of the middle turbinate is what we've been talking about here. And that's being compared to your classic CRS with nasal polyps. So we see that the polypoid change of middle turbinate group is significantly younger, and that is often associated with allergy, younger age. They have less chronic rhinosinusitis and significantly more allergic rhinitis. Furthermore, we can see that there are significant differences in the Lund-Mackay score, which is the CT scoring system. And we note that the patients with polypoid changes of the middle turbinate have significantly less disease on the CT scan, just as we saw in the example that I showed previously. So keeping in mind this association of polypoid changes of the middle turbinate with allergy, as was shown in some observational studies from various locations, let's move on to the actual entity of central compartment atopic disease. And this was initially described by our group in 2017, and it's essentially polypoid changes or frank polyposis of the middle turbinate, superior turbinate, and the nasal septum, especially the posterior superior nasal septum. And these findings have also been associated with allergy or atopy in various studies. On CT scan, we can see up in the right-hand corner that there are some fairly classic changes that we can see on scan, and that includes kind of a central opacification. So we see a lot of mucosal disease in the center of the scan, kind of in the center of the nasal cavities associated with the middle turbinates. And then if we look laterally in the sinuses and superiorly, we see less disease. So laterally in the maxillary sinuses, laterally along the lamina papricia or medial orbit, and then superiorly along the ethmoid roof. And that pattern is different than what we see in classic CRS with nasal polyps. So here's a case of central compartment atopic disease. This is a 77-year-old woman who complains of nasal congestion for many years. She was initially evaluated in 2009, keeping in mind that this is prior to the description of middle turbinate polyposis being associated with allergy and prior to the description of central compartment atopic disease. At that time, she had failed medical therapy, continued to have symptoms, and was advised to have sinus surgery. That surgery was delayed because she had some cardiac issues, and then she re-presented again about 10 years later with continued symptoms that were fairly similar to her initial presentation. So here's the CT scan, again, anterior to posterior coronal views. On this scan, you'll note that there is some more sinus disease than we saw in the initial scan, but I want to highlight that the vast majority of the mucosal disease is centrally located. There's clearing laterally and superiorly in the maxillary and ethmoid sinuses. And that pattern continues throughout the patient's sinuses. This is a surgical video of the same patient. Looking at the patient's left nasal cavity, we can see a large polyp. And as we look at that polyp, we can see that it's closely associated with the nasal septum. It's actually attached to the nasal septum. Looking a little more posteriorly beyond that polyp, we can see the middle turbinate, and that middle turbinate has polypoid change. So that's polypoid change directly on the middle turbinate. And so in this video, we're going to go ahead and resect that big polyp associated with the septum. And as this polyp comes out, you can imagine that this patient is going to have significant improvement of her nasal congestion once all of this polyp is cleared. So just kind of taking that down to its base along the nasal septum, and then we can see better that middle turbinate and the polypoid change anteriorly, and then a large polyp associated with the turbinate laterally. So this particular patient was enrolled in a study that we had that looked at local allergen-specific IgE in the nasal cavity, and you can see that on that test, she had multiple positives to various classes. So the patient was sensitive to various allergens from various classes. Pathology of central compartment atopic disease typically shows what you're seeing here. So on the right-hand side of the screen where the arrow is, that's the polypoid change. And then where the star is, you can get a sense that there's probably quite a few eosinophils. And as we look at a closer, more high-powered view, we can see that there are distinctly clusters of eosinophils present. So there have been some other investigations of central compartment atopic disease and its potential association with allergy. This is a study out of the University of Pennsylvania that looked at various categories of patients with sinonasal disease, ranging from classic allergic rhinitis without nasal polyps or CRS, and then also looked at various categories of CRS and compared the sensitivity patterns of these patients. So in the table on the left-hand side, you can see that that's central compartment atopic disease versus allergic rhinitis. And basically, the sensitivity patterns were almost exactly the same, with the exception of weeds. So there was only one class of allergens that differed in sensitivity between central compartment atopic disease and allergic rhinitis. So in this study, central compartment atopic disease looks a lot like allergic rhinitis. When central compartment atopic disease was compared with CRS without nasal polyps, there were multiple differences in sensitivities between the classes, and you can see those in bold in the table on the right. When central compartment atopic disease was compared with allergic fungal rhinosinusitis, the sensitivity patterns were fairly similar, with the exception of various molds. And I think that that's kind of inherent to what we would think about allergic fungal rhinosinusitis, that there might be some differences in the sensitivity to molds compared to other allergic diseases. And then there was also some variability between central compartment atopic disease and chronic rhinosinusitis with nasal polyps. So why do we think that this occurs, this allergen sensitivity with polypoid changes in the central nasal compartment? The current theory is that it relates to nasal airflow. And you can see a computational fluid dynamics representation on the left, and then a diagrammatic representation on the right of nasal airflow. Nasal airflow occurs within the nasal cavity in a bit of an arc, so sort of entering the nares and then passing over the turbinates, hitting significantly along the anterior aspect of the middle turbinate. And so that is sort of the current theory of why these allergens may be deposited along the anterior aspect of the middle turbinate, and then in predisposed individuals cause edema, polypoid change, and potentially frank polyposis. So our group looked at some of the variability in sinonasal allergen deposition in CCAD, and oftentimes we'll see some asymmetric involvement in central compartment atopic disease, with one side being significantly more inflamed or polypoid than the other. And so we investigated that, and you can see that here. So an example of the asymmetric CCAD would be seen in this CAT scan on the left-hand side. You can see that there's a lot of central disease, mucosal thickening and opacification on the patient's left, and less so on the right. And so using a computational fluid dynamics model, there was a CT scan taken from a 25-year-old healthy female without any sinonasal pathology. And our colleagues in Australia performed the actual analysis by injecting 30,000 particles to the front of the nose and recording allergen deposition. And then as part of this study, the middle turbinate was actually virtually resected, and the pattern of deposition was subsequently evaluated. So there were multiple sites examined, including the nasal septum, various aspects of the middle turbinate and superior turbinate, and we can see some of the results here. So this was a pollen sphere presented to the nasal cavities. You can see the results from the right nasal cavity on the left-hand side of the screen, and the left nasal cavity on the right-hand side of the screen. And there's significantly more deposition on the anterior aspect of the middle turbinate on the right, compared to most of the deposition along the septum on the left. And then various other particle shapes were also presented, including an aerodynamic sphere and a pollen ellipse. And you can see that there are some differences here. In a different type of a different way of representing these results, we can see the right and left sides, left on the top, right on the bottom, and then moving from left to right, preoperative with the turbinate virtually removed, and then postoperative. So in the preoperative analysis, you can see the deposition kind of graded in different shades of red and blue, and then the turbinate virtually removed, and then finally with the turbinate removed and then the allergen particles presented. And when the turbinate is removed, there's substantially more deposition on the septum. So kind of keeping these findings in mind, there was additional investigation of how computed tomography or CT scan findings may potentially help differentiate different types of chronic rhinosinusitis and what some of the findings can be that are associated with allergy or central compartment atopic disease. So these are some of the major ones. So number one, a lot of mucosal thickening or opacification along the nasal septum, and you can see that on the patient on the left-hand side. Relatively low Lund-Mackay score, so less sinus opacification, less sinus mucosal thickening in pure central compartment disease. And then finally, as the central compartment disease gets worse and there's more polyposis, more polypoid change in the central compartment, we get some oblique orientation of the middle turbinates and post-obstructive secretions trapped in the sinuses, which can cause increased sinus opacification. You can see that on the right. It is important to note, though, that radiology alone is not very predictive of identifying central compartment atopic disease or identifying patients that are more likely to be atopic. And that's evidenced by this study here, where they looked at endoscopic versus radiologic central compartment atopic or central compartment disease and its association with atopic status. And you can see that endoscopic central compartment atopic or central compartment disease, where they actually saw the polyps or polypoid changes coming from the turbinates and structures of the central nasal cavity, was better at predicting atopic patients. So radiologic studies can cause you to consider atopic disease, but really central compartment polypoid findings are best noted on endoscopy, where you can trace the polyps back to their origin of the central compartment structures. So we've talked about how these patients are likely to be allergic, and often that's identified on systemic testing, skin testing, or serum allergen-specific IgE. But I'd mentioned earlier that we had done a study to look at local allergen-specific IgE, kind of keeping in mind the idea of local allergic rhinitis and the thought that central compartment disease tends to show pretty exuberant inflammation and polypoid change in the central nasal cavity. So the question was, could patients with central compartment atopic disease have local allergen sensitivity that's contributing? So in this study, we used 3 different types of allergy testing. So systemic testing with skin testing and serum specific IgE, and then local testing that examined for central compartment local allergen specific IgE. So brushings were performed to collect nasal secretions and any tissue that was shed by this particular method, and immunocap was subsequently performed on these specimens. So you can see up in the top table the demographics of the patients. There were 15 patients in this study. And then in the table below, you can see the various number of positive allergen or antigens that were identified on testing in the 3 different testing methods. So the participant number is in the top row, followed by the number of positive testing antigens, the number of positive serum allergen-specific IgE antigens, and then the number of positive central compartment allergen-specific IgE antigens. And you can see that actually in the local allergen-specific IgE testing, the median number of positive antigens was the highest. This is a little bit of a busy table, but I really want you to kind of focus on the colors overall. So the test antigens in the allergy tests that was performed are over on the left-hand side. The participants are on the top, along with their eosinophil count and total IgE. And we can see that in the green boxes, there was concordance between all 3 testing methods for those particular allergens. In the red boxes, we can see that the systemic methods of testing were discordant. And I really want to highlight the yellow boxes. And the yellow boxes actually show the various allergens where they're both of the testing methods that are systemic in nature, so skin testing and serum allergen-specific IgE were negative. However, the local allergen-specific IgE was positive. And so in 4 patients, there were allergens identified on local allergen-specific IgE testing that were negative on systemic testing. So we thought that this was pretty interesting finding and maybe helpful for future diagnosis. We can also see here in the middle table that the correlations performed across the different testing methods were all significant. The highest correlation was between central compartment allergen-specific IgE and serum allergen-specific IgE. So as we think about central compartment atopic disease, how does it really differ in some of its characteristics from other CRS with nasal polyp subtypes? We investigated this in a study of our patients looking at allergy prevalence and asthma prevalence. And you can see here that across the various classes, there was significant difference in allergy prevalence, with the highest allergy prevalence being in allergic fungal rhinosinusitis and central compartment atopic disease, and the lowest being in chronic rhinosinusitis with nasal polyps not otherwise specified. And the significant differences are noted by the bars as well as in the list on the right-hand side. With regard to asthma, the highest prevalence was in aspirin exacerbated respiratory disease, which is not particularly surprising, and that was significantly different than all the other groups. But particularly notable is that allergic fungal rhinosinusitis and central compartment atopic disease had the lowest prevalence of asthma in our cohort. What about the inflammatory characteristics of central compartment atopic disease? This has been investigated in various studies, both from the US and abroad. These results are from a collaborative study that was led by Vanderbilt University that we also were involved with. You can see here that this study involved 253 patients with CRS with nasal polyps who were undergoing sinus surgery over the span of about 7 years, and they were divided into the phenotypes that are similar to the previous study that I was describing: central compartment, aspirin exacerbated respiratory disease, allergic fungal rhinosinusitis, and CRS with nasal polyps not otherwise specified. You can also see that in this particular study, the characteristics of the patients were similar to what I've previously described, with a relatively low prevalence of asthma in the CCAD cohort, relatively high prevalence of allergic rhinitis, and also in the CCAD cohort, the number of prior sinus surgeries was relatively low, and we'll talk a little bit more about outcomes here shortly. So these are the things that we've noted. In the mucus cytokine analysis, the red column is the CCAD patients. There were lower levels of IL-6, 8, 10, and interferon gamma, as well as eotaxin relative to other groups, and also reduced levels of the type 2 cytokines IL-5 and 13 relative to allergic fungus and AERD. And particularly interesting is the fact that the CCAD group, which is circled in green, had a very homogeneous inflammatory profile, as you can see in this plot here. And that is compared to the more heterogeneous inflammatory profile of the other subgroups. So when we kind of keeping the inflammatory characteristics in mind, this group out of Sydney, Australia, led by Richard Harvey, investigated tissue inflammatory markers in central compartment atopic disease versus eosinophilic chronic rhinosinusitis, sort of classic eosinophilic rhinosinusitis. And you can see here in the table on the right-hand side that the classic eosinophilic chronic rhinosinusitis tended to have more severe degree of inflammation, as well as a higher degree of tissue eosinophilia compared to central compartment atopic disease. And so that sort of goes with what I was describing in the previous study, considering the severity of inflammation. Also, when considering eotaxin 3, which is associated with eosinophil chemotaxis, the eosinophilic CRS group had significantly more staining intensity of eotaxin 3, or correction, a significantly higher total eotaxin 3 score and almost significant staining intensity in the higher level categories. So I mentioned previously that we'd talk a little bit about patient outcomes. We have examined this with respect to central compartment atopic disease compared to other chronic rhinosinusitis subtypes. And you can see here in this cohort of about 132 patients undergoing surgery from 2012 to 2019, that central compartment atopic disease tended to have less polyp recurrence and undergo less revision surgery than some of the other subtypes. We classically think about AERD and allergic fungus as being more recalcitrant, and this study here kind of gives some credence to why it's important to identify these subtypes so that we can counsel our patients on recurrence and recalcitrance and potential need for additional surgery or additional increased treatments in the future. We're often asked about the use of immunotherapy in allergen immunotherapy in patients with chronic or with central compartment atopic disease. Thanks to the group in Sydney, Australia, we're starting to get some evidence towards this question. So this was a retrospective study that has just recently been published in 2024, looking at 86 central compartment patients who underwent allergen immunotherapy or didn't. So about 37% underwent allergen immunotherapy. And at 12 months post-surgery, the immunotherapy group had less edema of the middle turbinate and also had less pharmacotherapy requirements. So particularly with respect to topical intranasal corticosteroid use. And you can see here from this paper some of the examples of middle turbinate edema, polypoid change, and how they graded the different findings. And we can see here the particular results that they had with respect to middle turbinate edema, and how the patients on allergen immunotherapy, which are in the first results column, tended to have a lower degree of middle turbinate edema compared to the patients that were not on immunotherapy, and then also with respect to corticosteroid irrigations in the lower rows. The final thing that I'll talk about briefly is some of the geographic differences. So the majority of studies of central compartment atopic disease have been published out of the US, Australia, or Asia. And so some of the findings that are being published and seen in some of the Asian cohorts tend to differ a little bit than compared to some of the studies from the US and Australia. And so here are just some examples of those findings. So these are some relatively recent studies from 2021 and 2022, and you can see the various patients that were included. So central compartment atopic disease in the first two, central compartment atopic disease compared to what was termed laterally dominant nasal polyps, so sort of classic nasal polyps. And then in the last row, central compartment atopic disease compared to eosinophilic nasal polyps and non-eosinophilic nasal polyps. Overall, to kind of summarize these findings with regard to allergen prevalence, although the sensitization to aeroallergens in these studies tend not to be as high as what is seen in the US for the most part, they do tend to have more aeroallergen sensitization than the comparison groups in the studies. With regard to asthma prevalence, the findings are a little bit more disparate with respect to geography. And you can see that as highlighted in red in the asthma prevalence column. So the findings that have been seen in some of the studies out of Asia tend to differ compared to what is being seen in the US with regard to asthma prevalence, which may potentially be explained by the differences in etiology of asthma and some of the associated inflammatory conditions. And then on the far right column, you can see some of the other findings of these studies. So as we summarize and kind of bring this to close, as I mentioned, the evidence for central compartment atopic disease is growing. Most of the studies that have come out have been observational in nature, so case control, cohort, et cetera, relatively low levels of evidence. I think that we will gain more evidence over time, but you can see here some of the results of the ICAR rhinosinusitis document looking at inhalant allergy as a contributing factor for central compartment atopic disease. The ICAR allergic rhinitis document published in 2023 shows that the evidence is growing. So over time, we're going to learn more. And in the EPOS document out of Europe, I will highlight that central compartment atopic disease has been included as one of the type 2 dominant diffuse bilateral categories of primary chronic rhinosinusitis. So what do we need in the future? We need more investigation of inflammatory profiles in central compartment. We need additional understanding of geographic differences, further evaluation of the role of allergen immunotherapy, and we really need to solidify the diagnostic criteria for central compartment atopic disease so that patients can be well categorized in studies. So as of right now, I would put forth that central compartment atopic disease appears to be a distinct subtype of sinonasal disease that is associated with allergy, at least in initial observational reports, but we still need to understand this disease better. And as clinicians, we need to recognize these findings to allow for appropriate patient management. Thank you so much.